I will shed the light on you remember the main players as a cause of atherosclerosis and the cardiovascular outcome. They are hypertension, diabetes, dyslipidemia, and obesity. These are the deadly quartet. But their coexistence is very important. When both of them coexist, the development of complication is augmented in a skyrocketing manner. And hypertension and diabetes are the pathophysiological changes start by development of insulin resistance. And insulin resistance is the main pathophysiological problem before the development of the vascular complications of those two diseases. Both of them are interlinked. There are common denominators for these diseases: endothelial dysfunction, arterial remodeling, atherosclerosis, dyslipidemia, and obesity. At the same time, you know, hypertension is associated with overactivation of the renin-angiotensin-aldosterone system, accompanied with oxidative stress and reactive oxygen species. Therefore, new novel agents appear in the field in order to modify or to modulate these players. And you remember the studies which have been conducted later on the use of SGLT2 inhibitors, for example, and GLP-1 agonists. They modify the pathophysiological basis of diabetes, not through their glucocentric effect, not through glucose control, but through other channels in order to modulate or reduce the bad outcome, which is the cardiovascular or the different vascular complications, whether micro or macrovascular complications. So we are looking forward to have a molecule which is protective, which is vasoprotective. We are working beyond the glucocentricity. Our goal previously, in the previous 2 decades or 3 decades, we concentrate on the glycemic control. Our goal is the reduction of the A1C down to the target, but nowadays we are playing away from the target, beyond the target, beyond the glucocentricity. The presence of type 2 diabetes increases the chance of development of cardiovascular disease by 2-folds. So a patient with diabetes can develop cardiovascular disease as twice as non-diabetic counterparts. At the same time, the presence of diabetes, the development of vascular disease, for example, acute coronary syndrome, the presence of diabetes has a negative impact on the fate. This patient has got sky-high risk of development of reinfarction and heart failure when we compare those with non-diabetic patients. And diabetes is regarded as a disease of vasculopathy, disease of the vessels. As I've said, there are bad news, really. And these bad news come from the fact that the development of vasculopathy starts very early, at the time of development of insulin resistance, at the time of development of prediabetes. And therefore, we have to work hardly in order to discover those people, not the diabetic people, but the pre-diabetic people which are at sky-high risk of development of vascular diseases. So, you remember the glycemic status, glucose, and the duration of hyperglycemia are known to augment the development of microvascular complications. But if we modify this target, we reduce the plasma glucose, we are going to have a positive impact on the microvascular complications. But the impact on the macrovascular complication is a bit low. So therefore, it was less modifiable on the cardiovascular risk. The other modifiable factors, the hypertension and dyslipidemia, their modification is more fruitful on the macrovascular complications rather than if we compare it with the glycemic status, whose impact is on the microvascular complications. So, at the beginning of the story, when the patient develops insulin resistance, the adipocytes start to enlarge, and their stromal vascular fraction is going to attract macrophages. And the macrophages are going to surround these adipocytes, and the story starts by hyperphagia. secretion of cytokines, namely interleukin-6 and tumor necrosis factor, and this heralds the onset of insulin resistance, which is the phenotype of everything. These large adipocytes are full of triglyceride, and these large adipocytes, they produce very unfavorable media for the vessels: sky high LDL, VLDL, triglyceride, low HDL, followed by increased level of leptin and low adiponectin. At the same time, sky high production of non-esterified fatty acids, and you know the impact of these molecules, the non-esterified fatty acids, on the beta cells, and therefore you remember the twin cycle hypothesis when we work hardly in order to reduce the fat around the pancreas to salvage the beta cells from destruction and death or apoptosis. All this media is going to result in increased mitochondrial oxidative stress at the level of the vascular endothelium. And this defines what is being called the vascular aging: reduction of the vascular compliance, disruption between elastin and collagen, stiffness of the vessels, and increased pulse pressure and shearing forces. So the microvascular complications result, you know, with blindness, peripheral neuropathy, and neuropathy, and by the glycemic control we succeed to ameliorate these microvascular complications, as it has been proven by the UKPDS and DCCT. And these complications can be ameliorated by reducing the glycemic status, and the duration of exposure is very important. It has been said, the development of these complications is through the polyol pathway and aldose reductase pathway with the production of advanced glycation end products. And some studies have been conducted in this field by attacking the aldose reductase, but all these fail to achieve the target by producing a useful molecule. I think you remember the sorbinyl and the other molecule which attack the aldose reductase to ameliorate the microvascular complications, particularly peripheral neuropathy, but all these studies fail to achieve the target. The microvascular complications are associated with the increased chance of cardiovascular disease. The presence of hypertension, so they are intermingled. The presence of hypertension and retinopathy are associated with the progression of nephropathy. The use of medications to reduce blood pressure, particularly by ARBs, is going to reduce nephropathy and retinopathy at the same time. So, is there any common gene for these two players, hypertension and diabetes, with the others? I mean dyslipidemia and obesity. Really, there is no real common gene is evident. No real common gene is evident, but no single gene. But there are signals about the presence of immunometabolic gene such as JNK and nuclear factor kappa beta, and these genes there are speculations about the presence of heritability complex trait rather than a single well-defined gene that gather both diabetes, hypertension, and the resulting cardiovascular outcome. There are signals about the effect of messenger RNA, and you remember the messenger RNA is a non-coding part. It has got multi-functions. At the same time, it plays a role in tuning the gene expression, and there are signals which implicate this messenger RNA in development of these complications. So the effect of diabetes by itself on the microvascular complication, as I've said, pathologically, the main impact is on the capillary basement membrane with an effect on the endothelium and vascular permeability. These are the pathophysiological basis of hyperglycemic effect on the microvascular complications. By these genome studies, global genome studies, they fail to find a common gene for insulin resistance by the use of these genomic studies. So we have to target both the blood pressure and the glycemic status. By the UKPDS Advanced Study, Accord Study, and by the use of different medications, these medications, the antihypertensive drugs you can see, they may have, in a way or another, a vasoprotective role and reduction of the cardiovascular complications. And you remember, statin and clopidogrel have got some antioxidant effect. There are new novel molecules, and these novel molecules have got a protective role on the vessels. But the methodology or the mechanism is not well known, and these molecules have been tried on experimental animal models, such as bradoxolone, which has an effect on the vascular damage, and some molecules have antifibrotic effect, such as pentoxifylline and baricitinib. Those molecules, the new ones, have been tried in experimental animal models, but their use in a human being have been tried up to the moment. The other medications which are really doing in our daily practice, such as metformin, you know, metformin is going to act mainly by reducing the hepatic glucose output, but it has got another effect by activating the AMP kinase pathway, and this is going to inhibit the mitochondrial respiratory chain at the vascular endothelium, and this results in improvement of the endothelial biomarkers. Therefore, metformin has got a vascular protective role, and this has been proven by the landmark limb of the UKPDS. ما ضل شيء بعد خلصت. You remember pioglitazone, and pioglitazone has got an effect. It favors storage of non-esterified fatty acids, and pioglitazone has got a vasoprotective role on the macrovascular complications, and this has been proven by the proactive study. There are good news really. In the new medications, the GLP-1 agonist, particularly liraglutide, dulaglutide, semaglutide, these medications have got a protective role on the macrovascular complications. Particularly dulaglutide, it reduces stroke, and the reduction of stroke is a very difficult task really. The SGLT2 inhibitors are very useful. They reduce the plasma volume and augment ketones, and they have got beneficial effect on the cardiovascular system, and this has been proven by the IMPAREG and IMPRISE study. So reduction of the blood pressure, I think my colleagues, although I arrived a bit late, so reduction of blood pressure, I wouldn't talk about the clinical side, my talk is totally basic. Reduction of blood pressure to very low goals versus conventional goals. It has been proven by Swedish studies that reduction of blood pressure, particularly the systolic, to less than 120 is fruitful in improving the cardiovascular outcome, and versus those people which accept just below 140, but there is a sort of J effect here, and this J effect is apparent on heart failure and the total mortality. And for the sake of time, I have to stop here. Thank you for your listening.